Well, we're going to talk about transcatheter aortic valve replacement. Was called TAVI, it's now called TAVR. And the data that I'll be presenting is again by, we have the largest TAVR experience in the United States. We're neck and neck with Columbia University and Marty Leon. Our TAVR expert at Cedars is another cardiologist of Indian origin. It is Dr. Raj Makkar. And what we're going to talk about for the next 20 minutes is the results of medical and surgical therapy of TAVR, the complications of TAVR, and what the future directions will be. This is essentially the status report for 2014. So the two valves that we use at Cedars or have available to us are one, a balloon expandable on the left, and on the right, self-expanding, one from Edwards Laboratory, the other from Medtronic. Stainless steel versus nitinol, bovine versus porcine pericardial tissue. There are options, and it is not clear as yet which of the valves will styles will turn out to be superior. The data that I'm going to show you in the next few slides will be with the Edwards first generation valve, which is the one that I'm showing here. And I'm going to show you really, I believe, the most remarkable set of videos that I have seen in my 40-some years of cardiology. Here is this valve now crimped onto a catheter, and the catheter is then following balloon dilation of the aortic valve. This catheter with a valve mounted on it is passed into the aortic valve across the aortic valve leaflets. And there you see it positioned. Now we'll come down and deploy the valve. And what I want you to watch is, first you'll see the heart beating at a normal rate, and then you'll see pacing-induced heart rate of about 180, sufficient to drop the arterial pressure to around 60 to 70 millimeters. And when that happens, the balloon within the valve is then inflated. So let's watch. Normal heartbeat, and you'll see now there's paced, and now blood pressure drops, balloon inflated, balloon deflated, and there is the valve now in position. That whole procedure took less than 10 seconds typically. And now let's look at the valve in place, an aortogram, and you see that there's a normally functioning aortic valve, just as if it had been placed there by the surgeon. Isn't that really just an incredible set of pictures from what you might have ever imagined when you graduated from medical school? It's like placing a ship inside a bottle. It's almost beyond one's imagination until you see it done. So here I'm going to talk, I'm just show you the Cedars-Sinai experience. We have done over 13,000, we're between 1,300, we're between 13 and 1,400 TAVR procedures thus far. If you were to send us somebody, about 20% of the referrals we get are rejected for one of two reasons. Either because we believe that they are a better surgical candidate, that is, they are a low-risk surgical candidate, or at the other end, they have such sufficient comorbidities that we feel they probably would not survive a year. In other words, what has now become called frailty. So those are the two reasons dominantly for rejection for the procedure. The procedure is dominantly being done in very elderly patients. Our average age is 82. The time for the procedure skin to skin is about an hour and a half. The patient, most of that is taken up by anesthesia, etc., and placement of other devices such as transesophageal echo. The groin to inflation period itself is really quite brief. It's about 15 minutes. Our 30-day mortality is around 1%. Our disabling stroke rate now has fallen slightly. It was 5% and it's now down in the range of 3%. We take some pretty old people. Here is a 102-year-old man who is back for his 2-year follow-up following aortic valve placement. This is the 102-year-old man is this one. This is me, a little younger, and this is Raj Makar, who is our expert in TAVR. We do some remarkable things with this technology. I just put this in to show you that you can also do aortic valve-in-valve implantation. Notice on the left here that there is an existing aortic valve, and within that existing prosthetic aortic valve, we've placed a second percutaneous valve. It's inflated, and now over here you can see, remarkably enough, a normally functioning aortic valve. Valve-in-valve. Let's look at two sets of data on TAVR. This is from the pivotal trial called the PARTNER trial, to which we contributed substantially. The first part of the PARTNER trial is TAVR versus medical management. The second part will be TAVR versus surgical management. So let's look at medical management first. Average age, 83 in both the TAVR and medical management group. 92% of them class 3 or 4. In other words, you have to have severe aortic stenosis and you have to be elderly to get into this trial. And I think that's the way it will be until we solve some of the complications of TAVR. Here is the result at 2 years of follow-up for TAVR in green and medical management in yellow. In terms of all-cause mortality, similar graphs for cardiac mortality, about a really substantial gap in survival between the, or in mortality between the two groups, favoring the TAVR procedure. And that is the reason that this has become a procedure that has taken the world by storm in the last few years. It's because there really is not much question that it is superior to medical management. This is the, again, the same group, TAVR versus medical management and repeat hospitalization. And you can see that at 2 years, repeat hospitalization is only about half for the TAVR group compared to standard medical therapy. So there is an advantage both in terms of overall mortality, cardiac mortality, and repeat hospitalization. The conclusion that I would draw for you based on these data and our own experience is that TAVR reduces both mortality and rehospitalization in severe inoperable aortic stenosis compared to medical care. But what about now compared to surgical care? Here is the data now from TAVR versus surgical replacement, again from the PARTNER trial, now carried out to 36 months of follow-up. And fundamentally throughout that time frame, you see little difference, essentially no difference in survival between TAVR and aortic valve replacement. But does that mean that TAVR is equal or superior? Not necessarily. I think we can draw the conclusion that TAVR mortality rate is not different from the aortic valve surgery. But let's now talk about the complication rate of TAVR. Here, the data would seem to, visually, to suggest that there's not any difference in stroke rate over time between TAVR and valve replacement surgery. But if you look carefully at the two graphs at the beginning, you can see that the surgery line is below the line for TAVR throughout much of the course of time. And the reason for that is if we blow up that first few months following TAVR, that the 30-day stroke rate with TAVR in this database is around 5%, whereas for aortic valve surgery, it's about half that. So clearly, aortic valve surgery in this time frame for this serious complication is superior in the first 30 days. Now, it looks like way out here at 36 months that these tend to balance out, but this is a significant, one of the two very significant complications of TAVR. And if you do MRI scans of the brain before and after TAVR, you will find that there's evidence of emboli to the brain, even in people who have no symptoms, in about 50 to 75% of the people who have the procedure. Presumably that relates to the dilation of the valve with dislodgement of calcium and cholesterol from the valve during either the balloon inflation or possibly during the deployment of the valve. Interesting, as an aside, we are now, previously with the higher profile valve apparatus, we generally had to do a balloon valvotomy before we placed the valve, but with lower profile balloon and valve apparatus now, we can avoid the balloon valvotomy in a substantial percentage of cases. I can't tell you yet if that reduces the stroke rate, but I think it will. The second major complication of TAVR, well, first of all, let me draw the conclusion. TAVR carries about a 5% procedural risk of stroke, which may balance off against surgery over time. And as I showed you in our own data, we're now down closer to 3% stroke rate, but still, it still remains a problem. The second complication that you must know about is perivalvular aortic regurgitation. Here, from the comparison of TAVR versus aortic valve regurgitation at 30 days, where the color coding indicates severity. Here's the color coding over here on the far right. So the red is severe, and the purple is moderate. There's a substantial difference in terms of perivalvular aortic regurgitation between surgery and TAVR, and that persists over time. It's about 15% in the partner database. And the reason that that is important is shown in this graph. Look at the classification as none to trace, mild, and moderate to severe. And we look at mortality over 36 months. And you see that the mortality rate, if you have moderate or severe aortic regurgitation following the procedure, you have about twice the mortality rate of that group that has none or trace. So this is a significant problem that really must be resolved. The two problems, stroke and perivalvular regurgitation. The attempts to deal with this are being somewhat successful. We are now using the Edwards-SAPIEN 3 valve, and you see what has happened is that a cuff has been added to that valve that was not there before. Turns out that the aortic valve orifice is not always circular. It can be somewhat more elliptical, and if you put a circular valve into an elliptical orifice, you will have perivalvular regurgitation. There are also compounds that can be used to try to fill in a small area of perivalvular regurgitation. This is the Medtronic valve, which now also, it has a skirt on it that is an attempt to reduce aortic regurgitation. And this is a valve that we are just starting to test called the St. Jude Portico. We don't have enough experience that I can give you any insight as to its value or lack of value at the present time. The Medtronic valve is somewhat more difficult to place and has a higher, definitely a higher rate of pacemaker, need for pacemaker than does the Edwards. However, the Edwards valve with this cuff appears to have a higher need for pacemaker because of complete heart block than the previous version without the skirt. It's gone now to about 10 to 12% perhaps require a pacemaker because of complete heart block induced by valve placement. The other problem in terms of attempts to solve the difficulties associated, the complications associated with TAVR, are the development of devices to deflect or capture emboli. I do not know which of these will be successful, but I believe that one of them must be successful, or others that I haven't shown you here, in order for us to move percutaneous aortic valve replacement from the 80-year-olds down into the 60-year-olds, because we must get rid of this too high rate of stroke. There are various strategies. Some cover the three cranial vessels with a essentially a sac that is porous and collects it. Others, as you see here, go up into the individual vessels themselves. So there are various variations in the types of inventions, and no one really knows as yet which one will be successful. We're going to start trying this one from Edwards Laboratories. So transcatheter aortic valve replacement in 2014, the mortality rate is clearly superior to medical therapy and is comparable to surgical therapy in elderly patients. The principal limitations are the 5% rate of stroke and 15% rate of perivalvular regurgitation. Both of these appear to have potential solutions that are now being tested. They certainly, the solutions will certainly impact the percentage of patients who suffer these complications, but I can't tell you as yet what the new percentages will be. So technical advances are still very likely, and if complications decrease, I think you can anticipate that younger patients will become candidates, but only when these numbers fall from their current levels. So developing new technology is difficult. You may recognize this gentleman. There's a great deal of interest in this, in new technologies, but there's always going to be somebody who kind of questions, how good is this? First he'll say you can't get it into the aorta, and then he'll say, well, you got it in there, but I'm not sure that you can get it to stay. How long is it going to be until you find a solution? It kind of bends me out of shape to even try to think about that. And that idea about something to prevent embolus is a jazzy idea, but really, overall, when are you going to solve the problem of stroke and perivalvular insufficiency? But if you do, yes, then I will give you some applause. And so it teaches us that some people will be doubters until we finally succeed. So thanks so much for your attention.